Hello, oral surgery colleagues, and welcome to the Oral Surgery Podcast. I am your host, Dr. Richard Moore, an oral surgeon based in the United Kingdom. The aim of this podcast channel is to discuss ways of improving practice in oral surgery, thereby creating a better journey and patient experience, and allowing us as clinicians to become better oral surgeons. All discussions on this channel are based on personal experience and opinions, which should be thought-provoking and supplemented with further research and evidence-based practice. Without further ado, let's jump into this podcast. Hello everybody and welcome to this podcast. I'm delighted to be joined by a colleague and good friend, Judith Stocker. So good afternoon, Judith.
Hi, Rich.
So Judith is a consultant maxillofacial surgeon in the UK. And do you want to just give us a bit of a background about your kind of training and what your specialty areas are within maxillofacial surgery?
Sure. Being a UK consultant means, of course, that we're doubly qualified, but I have rather an interest in education, so I do a lot of teaching. So that includes teaching our junior dental colleagues, but I also do teaching nationwide for people doing implants. I have a private practice as well as my NHS practice. My NHS practice is largely trauma and pretty much general maxillofacial surgery, but my private practice is a lot of implants and pre-prosthetic surgery and bone grafting and the like.
Brilliant. Okay, so today we're going to talk a bit about post-op complications, and I think this is probably an area that frightens a lot of people, and it'll be aimed at really, not just specialist oral surgeons, but also perhaps those GDPs with an interest or anybody that's doing any kind of oral surgery work. And I think the key areas probably are pain, bleeding, infection, common complications like dry socket. Perhaps we'll touch on the antrum as well, because OACs and OAFs always crop up. And we'll perhaps finish talking about nerve injury, although that's a fairly subspecialist area, but perhaps not managed as well as it could be in the UK. So I guess common complications that I see, certainly in hospital and primary care, pain is a classic, swelling, bleeding not so much so, but certainly dry sockets, particularly with a lot of students that we teach, that we do obviously have a high incidence of dry socket. And we see a lot of patients that come through the acute service that are, poor dental attenders with poor oral hygiene. So would you agree common complications that you might see slightly different in secondary care?
I don't think we see much that's different, to be fair. We see a group of patients, as indeed do you, who have rather more complicated medical histories than perhaps some that are seen in primary care. So I think one of the things that I would always teach is forewarned is forearmed. So as long as you are well aware of their medical history and all the other things that could go wrong, I think bleeding is not something we see, because if we see patients who are on anticoagulants or who have other conditions, liver disease, for example, then we know in advance what we should do with them. So stitching and packing. So I think it's about preparing yourself for all eventualities. But infections, we get a few infections after or post-op oral surgery. We are, of course, changing our ways in with respect to antibiotics and oral surgery, and that's probably a whole topic in itself. But dry sockets, I think we don't have a student population to let do our oral surgery. So I think where possible, I think it's fair to say that our dry socket risk is not high. It's certainly around the 1% mark, but I wouldn't put it any higher than that.
Okay. Yeah, certainly you touched on bleeding there, and I think that's, I've done a podcast on bleeding, and there are fairly clear guidelines regarding antiplatelets, anticoags, etc.
Mm-hmm.
The infections, I've done an entire podcast with a couple of people about antibiotics, but I think that's important that we touch on that.
Mm-hmm.
So if we start with pain, because this is a classic, and again, it's something that patients should be warned about before you start. I certainly am of the adage that I give my patients ibuprofen if there's no contraindications, and paracetamol before I start with my local.
I think that's a great thing to do if you've got the facilities to do it. In the secondary care sector in the big teaching hospital where I work, it's actually a bit more complicated to give somebody even a one-off dose of ibuprofen, even though it's a great thing to do. It's something that we do in primary care, however. I do that certainly for all my minor oral surgery in primary care. So I think it's a great time to do it, but it doesn't have to be done. And I
Yeah,
think some practices wouldn't have the facilities to do that.
yeah,
So that's the time to think about it. But the other thing I would always say is warning your patients. If you prime your patients about how sore a procedure is going to be, then often they cope with it better. So in my consent form, I will put pain, swelling, bleeding, infection. So pain is the first one I'm going to put. So I warn them that they disappear off after their procedure. And the first thing they do as soon as they get home is take some suitable analgesia, depending, of course, on their medical history.
and what would so I guess the first choice of analgesic, generally speaking, would be a non-steroidal. Would you agree with that?
I agree, but I would also stand by the simple things. So I would go non-steroidal, but I would ask them to alternate it with paracetamol.
Yeah,
There's nothing wrong with paracetamol, and as long as you give your patients very strict instructions on how much they can take and when to take them, usually they're quite good at it.
yeah, and certainly those patients that come back with pain, if or if you're administering medication such as codidromol or dihydrocodone, I think you've got to kind of think about, particularly in primary care, what kind of procedures are you doing that require an opioid-based analgesic, and if you are doing something that requires that, maybe that should be done elsewhere,
I must
or
confess, I would be sorry, Rich. I would be really careful about dihydrocodone
yeah,
in primary care. It's something that it's not a very nice drug. It has a worth, sadly,
mm,
among some communities, and dihydrocodone it's not the best painkiller for the kind of things that we do.
no, no,
Non-steroidals are much, much better. I think if you are going to use a small dose of codeine, then something like an 8 milligrams of codeine and 500 milligram tablet of paracetamol. So that would be the trade name for that would be cocodamol or something like cocodamol 8-500. I think that's acceptable, but
yeah.
I would worry about dihydrocodone.
And I think the other thing with the opioids, the dihydrocodone, is sometimes patients develop that dependence, don't they, quite quickly?
Yeah,
Um,
and we do see some patients who come and they've taken quite a lot of codeine over several days, and then they tell you they feel terrible in and
mm,
aside. And it turns out they feel terrible because the poor souls haven't opened their bowels for 4 or 5 days.
yeah, yeah.
So it's not to be underestimated the effect of codeine.
And the other thing just to touch on is those patients that don't appreciate the compound analgesics that have taken cocodamol, paracetamol, and ibuprofen, and
Yeah.
that bit of education to say actually that cocodamol, that there's two drugs in there, and you've just doubled up your paracetamol. So I think that's important. I mean, sometimes I say, or I'll prescribe some codeine as not a compound analgesic, and say take this in the evening just as a bit of a breakthrough pain relief if I think it's going to be particularly bad. But again, most pain relief is controlled fairly well for oral surgery with ibuprofen and paracetamol.
I think that's fair. The only times that I think patients really do suffer is the poor soul who's got alveolar osteitis, a dry socket.
Sure. Yeah.
These are the kind of patients, as you know, who will come and see you, and it's almost like they've got this terrible look on their face that says, "Please give me a local anaesthetic to take this pain away."
Yeah.
And so I think a dose at night of codeine is actually quite a good idea.
And the other thing that we can do for these patients, depending on the cause of their pain, is local anaesthetic or a block. I mean, particularly if it's a non-odontogenic pain and you're in the realms of trigeminal neuralgia, if you can give a
Mm,
block with Marcaine or something, that
mm.
often buys them quite a bit of time while you can manage them appropriately with a referral or contact the GP or referral onto secondary care.
And can I just add there, and the thing about managing dry sockets is these things are incredibly tender. I mean, it's a horrible thing to have a dry socket. So I would always encourage people to give something. It could be Marcaine if you have access to it, but I think probably more of our Articaine might be better for our primary care colleagues. So giving somebody a local infiltration of Articaine is probably a very nice thing to do for the patients.
Yeah. And peak pain, do you think, I guess depending what you've done, 24 hours, 48 hours post-op?
I think I would always say you're not going to have the worst until 48 hours have gone, and
Yeah.
that applies to pain and to swelling. So patients will say, am I going to swell? How much is it going to swell? Well, you're not going to know really until 48 hours have passed, and everybody's different. But I think going back to what I said earlier, if you prime patients properly, and you say, listen, this is going to be really sore, you're really not going to like me very much, often they'll come back for a review and they'll say, do you know what, that wasn't as bad as you said it was going to be, at which point you've kind of done them a favour, you've primed them properly.
Yeah, definitely. I think I always paint the worst case scenario in some respects.
Completely
Um,
agree.
so swelling, other ways of so obviously pain comes with swelling, and swelling comes with pain. Uh, have you got any tips or tricks for managing? Because you see particularly, I don't know what company it is, but for osteotomies they try and sell these
Yeah.
cool pads that you
Mhm.
strap onto your face.
They do work. There's actually some really good evidence for those, but I think,
Okay,
and they use them, of course, my plastic surgery colleagues use them for some of their facelift patients as well.
okay,
So there is really good evidence for those. However, you've got to hire the machine. The patients have to hire the machine, and
ah,
then they pay for the disposables. So a better way of getting around it would be these little disposable cool packs. These things that have
yeah,
granules inside that you have to shake. We give those out for all of our bigger oral surgery cases in primary care, and
okay,
definitely all implant cases. And I also put a little bit in the post-op instructions, urging caution with ice, anything with ice in it.
mm,
So if they're going to use a bag of peas, which is fine, make sure it's well wrapped, because of course you can do yourself a damage with something that's too cold.
yeah,
Um, the other thing I'm very fond of also is these wheat packs. So, in cases that might not be immediately post op, one of these wheat packs that you put in the microwave to warm up, conversely, particularly for TMJ pain, they're quite useful. So, they're not to be discounted either. But the cool packs are quite good.
did you say wheat or heat?
Wheat. They're little
Wheat.
wheaty bags.
Oh, okay.
You can buy them just about anywhere. Chemists have them. I've even been in a garden
Yeah.
centre that has them. And it's a bag of wheat, grains of wheat that you stick in the
Oh.
microwave and that you warm them up. They're brilliant for TMJ pain, and they're reusable and they're natural. So there's no chemicals. I mean,
Oh.
the ice bags, the chemical things that you shake and agitate when they go free cold, that's got chemicals in it. So I'm sure lots of patients appreciate
Oh.
the bags.
Yeah, I've heard of the heat pads, but I didn't know they were wheat.
Oh, no,
Um,
the heat bags are brilliant.
and you give that? Did you say for all of your implant patients or just the bigger cases?
Or the ice packs, the chemical bags, I give to all my more major oral surgery.
Right.
Anybody who's had bone graft,
Yeah.
anybody who's had an implant, they all go home with them. And if they don't want to use them, then they're great for injuries at home. So if you've running around in the garden and you sprain something, these things are very useful to keep at home.
And you tell them to start that irrespective of the outcome of the swelling? Do you start that evening or
Do you
use them
know, I
regularly?
don't for everybody.
Okay.
But it's about you look at your patients, don't you? And there are
Mm.
some patients who walk in the door and you think, yeah, I'm afraid you're going to swell.
Yeah.
And it's a terrible thing to say it's the redheads, because we anecdotally always say redheads bleed, but sometimes they do. But there are some patients who'll come and you'll think, yeah, you've got really delicate skin, you're just going to swell. So it depends. It depends.
Interesting you say anecdotally about, I'm going to say fair-haired population uh, bleeding. There is an article in the BMJ, I think it's written by an anaesthetist,
It's a
saying,
few years ago saying that there's no blood abnormality. Is that the one you're
yeah,
thinking of?
yeah, but that they do bleed. And,
Yeah.
it's
And
true, isn't it?
it absolutely is true, and it's something that we do. The patient walks in the door. Of course, I always get caught out by the girls who've walked in, and actually their hair is not their own natural colour, and I
Indeed,
assume
yeah.
they're redhead. But yeah, redheads will often ooze a little more.
And what's your opinion on prescription of or administration of steroids for prevention of swelling, depending on procedure?
I think it depends on the procedure. I certainly have no issue in a small dose of steroid, certainly if we're giving patients intravenous sedation.
Mm.
So, my sedationist will ask me prior to administering sedation if it's going to be prolonged, would I like a small dose of dexamethasone? And so, we'll do that for those patients, but not for anybody who's undergoing routine stuff under local anesthetic.
Okay. It's interesting, isn't it? Because certainly all my GA patients get 8 milligrams of Dex, but that's really is an antiemetic from the anaesthetic
Yeah.
side.
And,
So it's
and
a bit.
And we've actually moved away from that,
Ah.
curiously. In the day case setting in the hospitals where I work, there are very few patients we now give that to. So I think it was probably something that we used to give a lot more when with some
Mm.
of the older general anaesthetic agents. So it's not something we give to every patient.
Okay. I mean, I do give it orally for bigger cases like full arch or zygos, but um, not. And I'll give it IV if I'm doing a sedation case. But again, it's not something that I give regularly. Certainly in the States, they give it locally to the site after whizzies. So they'll inject it into the buccal mucosa.
I, I've got no experience of any evidence to relate to that. Do you have the evidence to support
There's a
that?
couple of papers I'd have to trawl my Dropbox though, and I don't do it. I'll be honest, but it's
Um,
something that I keep thinking I should look at.
but I think you also should look at our American colleagues. They have a slightly different training to us. They do an
Yeah,
awful
that's
lot
true.
more anesthesiology, as they would say.
Yeah, yeah,
So they are much hotter on that sort of thing. And of course, a lot of their surgery is principally office based. So even
yeah,
some osteotomies are office based. So they're a lot more used to it than we are.
yeah,
And I think I would struggle to persuade my primary care practices that we should be keeping steroids in the practice just for the purpose of giving that, because
yeah.
usually I don't find it a problem.
Well, there's probably a short supply since COVID, isn't there? Because Dex
Yeah,
was the
exactly.
drug of choice. Yeah. Okay, so I think from a swelling pain perspective, we'll come on to dry socket in a bit, but I don't know. Is there anything else you want to add to that little section?
I think it's very useful for primary care practitioners, certainly, to acquaint themselves with the analgesic ladder principle.
Yeah, the
Um,
WHO.
yeah, the WHO thing. It, it used to be the case that everybody was very keen on the dihydrocodone. In the UK, it's DF118. But also, they were very keen on codidromol and coproximol. Now, coproximol has disappeared, but I don't think codidromol is much better. And there are much easier ways of managing things than going straight for the biggest drug.
Yeah,
And it's all about
it's this.
quantification,
I
isn't it?
gotta say, it's the same with naproxen, isn't it? You know, you often
Mm,
get a patient who's been to A&E, come back and they've got codeine, naproxen, and
yeah,
it's all fairly hardcore stuff.
yeah.
I'm not aware that there's any strong evidence to suggest things like naproxen or diclofenac are any better than ibuprofen in oral surgery.
I'm not aware of anything for oral surgery. Certainly for the rheumatology patients, naproxen is more favoured
Yeah,
these days. The only other thing I would add for our primary care colleagues is just to be a little bit cautious about patients with ibuprofen, so non-steroidals in the older age group.
mm,
Acute
sure.
kidney injury is one of these things that our dental colleagues probably don't know much about. And this is a kidney injury that's caused by non-steroidals quite commonly. And even in hospitals, it's something that we weren't really well aware of until the last, I don't know, 7 or 8 years. And if you put somebody on quite a dose of ibuprofen, even, and you do that for a couple of weeks, it's perfectly feasible for you to tip a kidney that was failing into a kidney that has failed.
Yeah. And I guess the other thing to mention with maybe longer than a week's course is to consider a proton pump inhibitor
Yeah,
for your non-steroidal.
I think that would be very sensible, but of course, our primary care GDP colleagues won't be able to prescribe that. They will, however, be able to advise the patient to either go to their GP, but of course, a lot of PPIs can be bought over the counter now.
Yeah, yeah,
And I always advise people to take painkillers with food where possible. And if there's any history of them having any dyspepsia or anything with non-steroidals, then they probably should avoid them.
avoid. Yeah. Okay, brilliant. Okay, bleeding, which I always get asked about bleeding as a hot topic, and I think there are some. obviously you would assess the patient's bleeding risk from their medical history and their drug history. So antiplatelets, anticoagulants, self-explanatory really, and we'll touch on those in a sec. But when patients say, "Oh, last time I had a tooth out or something at the dentist, I bled cupfuls," and I think they always, well, maybe not always exaggerate, but that mixture of blood and saliva is always a classic.
Yeah,
But also there are some key questions that I know you are fairly keen to ask about
yeah.
things that have happened in the past.
I think the story about the cupfuls of blood is a bit akin to the dentist had his knee on my chest when he took my tooth out kind of thing.
Indeed.
So it's not that I take these things with a pinch of salt, but my next questions to the patients then, well, okay, so you've had a bleeding tooth socket. Have you ever had any other operations? Have you had any kind of surgery at all? And so for ladies in particular, I would ask about anything, any gynecological procedures or obstetric procedures. And of course, I would ask all patients, have you had your tonsils out? So if you haven't had a bleeding problem with tonsillectomy, childbirth, for example, or they don't have any serious problems with periods, then they are unlikely to have a bleeding problem. That's not to say
Yeah.
they might not have a bleeding problem. I have seen somebody who managed to get through a total abdominal hysterectomy who had von Willebrand's, who then
Hmm.
subsequently bled post wisdom teeth and then was found to have von Willebrand's. So it's not foolproof that, but it's something that you should ask about.
Sure. And then obviously, the other things, if you, I mean, I always say to men and maybe some women, if you're having a shave and you cut yourself, does it heal up fairly quickly? And do you bruise easily? Those kind of classic things. But on top of all that, we've got the medical conditions that you should be aware of, such as liver disease. I think people always get a little bit twitchy with,
Mhm.
oh, either alcohol dependence or liver disease. Should I do clotting? Should I not do clotting? Do I need to refer them?
It's a
What?
common cause of referrals to the hospital service. So the patients will take the dentist rather will take the history from the patient, and they'll elicit a history of alcohol excess. And the patient, it might be needs extraction in hospital. Patient drinks excessively. Well, the two don't necessarily follow one from the other. What I would say is that a patient who drinks to excess, who does have a clotting disorder, is highly likely to be known to our hepatology colleagues. It's not necessarily true, but it's highly likely. And I think it's something to be a bit cautious about. So use the other questions to supplement the stuff about how much do you drink. And if they're going to have a problem with liver disease related bleeding, they'll usually have some other signs or symptoms related to liver disease. Is that fair?
Yeah, yeah, I think that's fair. And then other conditions that you would patients who've got ITP usually know, don't they?
Yeah.
Or chronic
So
renal failure.
ICP just for it's Richard's code for idiopathic thrombocytopenia.
Yeah, sorry, I'm assuming knowledge. And then those medications risk of bleeding. I mean, the SDCEP guidelines, the Scottish Dental Guidelines, are really clear, and they identify those medications. And the obvious ones are obviously antiplatelets, anticoagulants,
Hmm.
cytotoxic drugs, long term non-steroidals,
Hmm.
etc. So do refer to those, and I'll put a link in the podcast to the Scottish guidance for if anybody's not seen them. And again, if you're listening to this and you're outside of the UK, you may have different guidance in your country. I mean, the common antiplatelets in this country are aspirin, clopidogrel, dipyridamole, prasugrel, and ticagrelor. There is another one on the market called cangrelor, and certainly, single dose 75 milligram aspirin. The guidance is just to treat them as normal. You might want to limit their treatment. But certainly the dual antiplatelets or the things like the clopidogrel, they do bleed, don't they? And I certainly would encourage packing and stitching those patients and limiting the treatment.
And I think the thing to be aware of is that you're not actually either lengthening your procedure too much or causing the patient undue harm by packing and stitching. So
Sure.
where in doubt, packing and stitching, assuming you've got the skill to do so and the packing to pack in it, is not an unreasonable thing to do where
Yeah.
you're a bit worried.
And also, a word of caution that some of the resorbable hemostatic agents on the market, some are animal in nature. So obviously, your patient needs to be consented for that.
Mm.
And I mean, I tend to use PRF, platelet-rich fibrin, that we've now got in the hospital. So that helps as well. but do
We like
be oh, well, you see,
yeah,
you
I
need to get
know.
yourself some funding. And
Agreed.
then I was going to touch on bone wax because I know that you and I, or I, had. I thought that would generate some entertainment. When I was Judith's junior, recalled putting rather a lot of bone wax
You know,
somewhere.
redhead,
That
seriously.
sorry.
She was a redhead.
Oh. And
Bone
yeah,
wax is brilliant stuff if you've got it. Bone wax is really good for a single bleeding vessel. When you do lift a flap for a lower third molar, there are patients that you will see, and you may have seen this, Rich. Have you ever seen that little blood vessel you'll see? You
yeah.
haven't
Actually, it's funny you mentioned it. My registrar only 2 weeks ago, we looked at the scan because they'd had a scan for this impact
uh,
today, and there was a retromolar
yeah,
canal, and lo and behold, it spurted, and he just popped a tiny bit of bone wax on. A
and
problem solved.
that's the best place, in my opinion, for bone wax.
Yeah,
The other place that you could use it is if you were trying to go through the wall of the antrum to do whatever you wanted to do in the antrum.
sure.
As you know, sometimes you will find a vessel, and if you didn't have bone wax, actually, that's a point. If you didn't have bone wax, what else could you use, Rich? I'd turn this into a test.
Oh, for the antrim
Yeah.
or just generally?
Well, somebody asked me this question the other day, and I thought, well, actually, there are some of these disposable pens that you can buy. Have you ever seen these things? It's a
Cautery
little,
pen.
yeah, little cautery pen.
Yeah,
Um,
we used to have them in the hospital, but I don't. I haven't used one for years. I guess
well,
you've got to be cautious where that bleeding's coming from in case there's a neurovascular
absolutely.
bundle.
Absolutely, but these things you can buy on the internet for about £8 each. And for the sake of having a tiny bit of cautery
Mm,
in your drawer, as it were, in your little armamentarium, I think they're a useful thing to have. However, there's always a but, and the
yeah,
but is that you need to use these things really carefully because if you apply them willy nilly, then you're in danger of burning something local as well
yeah.
as getting out your bleeding. We use a great thing called a hyfricator, which is a little wheeled trolleyed cart that it's quite expensive. In the UK, it's about £3,500. But if you're doing these things regularly, and you can either attach a monopolar forceps or you can
Oh,
attach a bipolar to it, it's a brilliant little thing.
oh, that's handy. Yeah. And
And
I guess the other kind of thing just to mention is if the patient's on an antiplatelet or anticoagulant, you need
mhm.
to know the reason they're on that because that might come with other complications as well
And
in your
would you stop
management.
your antiplatelet agents out of curiosity?
Say that again. Sorry.
Do you stop the antiplatelet agent?
No. The Scottish guidance for dual antiplatelet or single antiplatelet is not to stop.
Just a question. I have lots of dental, my referrers will say that the patients will come and they'll say that their dentist had told them to stop their antiplatelet agent.
Oh,
It's not something I would encourage.
yeah. The only one to stop is one with the DOACs. I think it's
Mm.
rivaroxaban if they're high risk of bleeding, so you miss the morning dose,
Yeah,
restart it in the afternoon. But if any doubt, then speak to the prescribing physician. Really.
agreed.
Um, so bleeding, I was always taught by an anaesthetic colleague of ours, it'll stop one way or another. Which is true. But ideally, you don't want your patient exsanguinating, which we've both seen. But in the first 6 to 12 hours, that clot should form, and it should be fairly firm, shouldn't it? And if it breaks down for whatever reason, we've then got post-operative bleeding. So managing that post-op bleed, I guess in primary care, you might not have to do it. Depends what kind of on-call or out-of-hours service that you run. But certainly in the hospital, when these patients come in, late in the evening, they're fed up, aren't they?
Mm.
It's horrible having a bleeding socket or oozing from your mouth. So it's being able to triage that patient that you need to see. And I think if the patient's phoned up and said, "I'm still bleeding," you are obliged to see them, whether you you might give them advice about pressure for half an hour and then call me back, and
Mm.
hopefully it will have stopped in that 30 minutes as long as they've sat down, rested. They've either used the pack you've given them or a dry tea bag, sit down and wait and time 30 minutes. But if it's still bleeding after that, you've got to see them really, haven't you?
You do, and I'm pleased to hear you mention the tea bag. I thought that was something that had died. The tea bag is very, very old-fashioned, but it does actually work. Although I would wrap it in a gauze before you used it. Um, Patients who bleed, what you have to do when you're triaging is weed out the ones who really just want it to stop, but really haven't done very much to stop it themselves. I always send them home with advice about not using a straw because that's quite a useful one. Sometimes
Yeah.
patients assume because they've had oral surgery that they need to use a straw, but actually that's just going to encourage bleeding. And the other thing that I'm very keen to encourage is some patients go out and you know that they're going to keep spitting because they
Mm.
don't like the taste of the blood and they're going to keep spitting stuff out and then they are going to bleed. But you're right, these patients come to you late at night, they're fed up, they're miserable, they just want it to stop. So in the hospital service, we have the ability to do a clotting screen, and that's the useful thing to do. So it's about stitching, packing. For us, it's about a clotting screen, but of course, for the novel oral anticoagulants, you can't do that.
Mm.
Um, so it's really a question of making them comfy and making sure they're not bleeding too much.
Yeah. And I think the key is to, if you can get in there, get rid of that clot that's in there, have a good look and try and identify if it is something you can control, either with your little bipolar or your bone wax, and maybe a bit of local just to make it a bit more comfortable. Obviously, there's that cautionary tale. If you're giving local with a vasoconstrictor, it's obviously going to help the hemostasis, but it might be that when that wears off, you're back to square
Mhm.
one. Um,
It is
but try
rare,
and,
isn't it, that we see
yeah,
anything that's serious. However, there are some terrible cases out there of patients who've come to significant harm
yeah,
from bleeding from a dental socket. So it's not true for people to say, oh, it's only a bleeding tooth socket, sadly. People
yeah.
with tooth sockets do occasionally come to harm.
And if they've been referred into you, would you get your juniors routinely to do bloods if they've been admitted?
I think if
Clotting.
they're admitted, I think it's appropriate for them to have
Yeah,
bloods. It is most unlikely you'll find anything in those bloods, but
sure.
you've got an opportunity when the patient comes through the emergency department to do some investigations, and I think it's appropriate that you do. In the same way that when we admit somebody with an infection, you've got an opportunity to see whether this patient is diabetic,
Yeah,
and I think it's
yeah.
appropriate to do.
And certainly in our trust, and this is routine for our hematology patients. And I guess the other thing just to mention is those patients with underlying hematological problems, clotting like von Willebrand's or haemophilia, then it's mandatory to get your hematologist involved with that because they do
It
need to be
is.
managed appropriately.
It is,
Um,
but we have a fantastic nurse-led service.
yeah, we do as well, and I think
Yeah,
that's
and that's
probably similar across the country, isn't it?
absolutely. So these patients are these days well worked up. I mean, you and I both have memories of years gone by where that wasn't necessarily the case.
Indeed.
But these days, the specialist nurses come and sort everything out, and actually, we tend to keep those patients overnight just in case.
Right. And actually, our patients go back to the haematology ward. They look after them. That's how good they are.
We haven't got
Um,
space for that.
and they're very keen on tranexamic acid, and they seem to prescribe that um, for both pre-op and post-op sometimes with the haemophilia patients. And I know people always ask me about, oh, should we have TXA in the practice? It's not something I kind of advise because the other thing you could do with a bleeding socket is your adrenaline ampule, which you would use for anaphylaxis. You can crack one of those, pop it on some gauze, and use that as pressure with the vasoconstrictor, but it might only be a short-term measure. But
And I
certainly, I
think
don't think,
that's sorry, Rich. I think that's very appropriate. I think there are things that you can do in primary care, and there are things you shouldn't need to do in primary care. So once you've exhausted your skill set and your knowledge base, it's time for somebody else to deal with it. So I think most of my primary care colleagues probably wouldn't be very happy to start using tranexamic acid. I can
yeah,
think of a couple who would, but I
yeah,
think if it's at the stage where it's really not doing what you think it should, it's time to call for help.
yeah. And it's getting that TXA as a mouthwash
Mm.
made up, isn't it? Because it's not. I don't think it's licensed,
It
and
isn't.
not every pharmacy would be happy to stock it. So
And it
yeah, and I think if you're thinking of that, there's obviously a reason you need it. So
And it did used to come in glass vials as well, didn't it?
yeah, for IV, I assume it still
Yeah,
does.
it does. And then you have the problem of how you get them open. I've certainly seen somebody cut themselves on a glass vial of
Yeah,
tranexamic.
yeah. So bleeding's quite, I think, key is in the history, and then obviously
Mm,
management for that acute bleed.
mm.
Which you touched on infection with that and admission and things. So I think we'll move on to infection. There are some at risk groups, and I think one of the things we need to mention now is sepsis, which is very much in the public domain, but certainly those patients who are at risk of an infection. And I think it's important to be able to distinguish between swelling and infection, because you get that classic patient who comes back and says, "Oh, I've got an infection." They've got a big fat face, but actually that's post-op swelling or edema. Whereas infection, you need to identify that and make sure that you've identified the differences between swelling and infection. Sometimes age, extremities of age, certainly the elderly population might be more at risk. Smokers, concurrent medical issues such as steroids, immunosuppression, radiotherapy, diabetes, we've talked about. So it's recognizing those patients before you operate to identify that they may be at risk of infection.
Sure.
But also,
Sorry, I keep cutting in on you. I do
that's all
apologize.
right.
I think it's as we talked about at the beginning. It's forewarned, isn't it? So the diabetic that comes in, and don't forget, patients that walk through our doors these days, we see so many type 2 diabetics or people who are on the threshold of being, oh, I'm almost type 2 diabetic, doctor, I'm nearly there.
Yeah.
I don't think it's unreasonable to give those people antibiotics in situations that require it. But again, as you say, it's assessing that patient. Is it swelling? Is it an infection? So is it hot? Is the patient unwell? Do they have any signs of pus anywhere? Is the tissue? There's a difference, isn't there, Rich, between a swollen sort of cheek, for example,
Yeah.
and an infected one. There's a texture difference.
Yeah.
So edema tends to be a bit squishy, whereas if you have infection, it tends to be a bit more. The word we like is indurated.
Mm.
So it's got a firmness to it. Is that fair?
Yeah, definitely. And recognizing, I'll ask you in a second about those patients that you would think, oh, red flag, they need to be either in the back of a yellow truck with blue lights on, or definitely need to send them to hospital fairly soon. But that recognition of sepsis, and there's a really good paper that I'll put a link to in the BDJ that Paul Coulthard wrote with some colleagues. I can't remember the other authors, looking at the recognizing the symptoms and signs of sepsis in primary care, like slurred speech or confusion,
Mm.
shivering, not passing urine, shortness of breath. They have that sometimes sense that they really don't feel well at all. Their skin might be discolored as well. So it's recognizing that early on and managing it early. And there's that sepsis 6 when they come into hospital that people need to jump on. But from a primary care practitioner, people always say to me, "Oh, I don't know when to refer this patient, Rich. When should I pick up that phone, or when should I prescribe some antibiotics and bring them back, or give them a call the next day?" And I think there are probably some key pointers from your perspective as to which ones you need to see pronto.
We worry about anybody with an elevated pulse, so somebody who is sufficiently unwell to be tachycardic. And it's a good practice to actually take somebody's pulse. It's not a problem. It's good practice for you to have a thermometer in the practice. And so if you can take their temperature and they're pyrexic, then it's not unreasonable for you to pick up a telephone and actually speak to somebody. If they're having difficulty speeching, and the classic speech that we really hate is something that we call hot potato speech. And what we mean by that is basically the tongue's not moving very well. The tongue is often raised. The floor of mouth, if you look inside the mouth, the floor of mouth will be raised in edematous, and the tongue doesn't do what it's supposed to do. It's not sort of agile as it needs to be. And if I thought that, then that's probably what we call hot potato speech. If they have any difficulties swallowing, and in particular, if they are actually drooling saliva, then that's absolutely good reason to pick up a telephone and have a conversation with somebody. We also are not very keen on swelling that starts to affect the eye, so the periorbital area, but it's airway, eye, swallowing, breathing. Oh, have I missed anything out? Have I missed
I
anything
think
out?
maybe just, yeah, neck swelling and
Yeah.
rapidly spreading infection, and
The other
I
thing that
think.
carry on.
Go on. No, you go.
The other thing that we really, really don't like is redness on the neck. So if you have somebody who's got a spreading infection on the neck and you can see that the skin is red, That's something that really concerns us. And actually, also, if the skin looks like it might have been red or it's swollen, but it stops blanching. So it gets this very unusual texture to it and it stops blanching or even becomes mottled. That's a really alarming sign for us of something called necrotizing fasciitis. So that's time to pick up a telephone.
Yeah. Um, and people always say, oh, oh, they've got Ludwig's angina. But I think realistically, it's not necessarily the label, is it? It's the clinical signs and symptoms that you've recognised that are the red flags that they need to go into hospital.
We don't see that many Ludwig's anginas. So Ludwig's angina is an infection whereby you get swelling essentially around your upper airway. So we're talking base of tongue, so submandibular, sublingual, base of tongue, and it can often be peritonsillar as well. So these are people whose airways will start to be a problem. They can't speak. They get the classic hot potato speech. And we treat them by using a tracheostomy. They get lots of big incisions in their neck to let out what you think is going to be pus, but actually often isn't. But we actually don't see very many of them. So I think it's not about diagnosing a Ludwig's angina. It's about you saying this patient's got difficulty swallowing, this patient's got difficulty speaking, or this patient is drooling, or they just look unwell. And it's fine to pick up the phone.
Yeah. And I think it's really important to pick up the phone rather than, well, I don't think people write letters anymore, do they? But rather than giving the patient a letter and bundling them off and saying, make your way to A&E and just give this to the receptionist. I think
Absolutely.
having a conversation with whoever's on call for MaxFax in the hospital is
Mm-hmm.
really important to hand that patient over. And to end on infection, I think there's a favourite saying that you and I both know, which is never let the sun set on pus.
Plus,
And it's interesting. We've got some overseas students on our master's program, and I got them to present about infection, and one of them said that as well. I was like, "Oh, that's really interesting that it's not just in the UK that saying is well known. So it's universal."
well, it's a truism, isn't it? It's
Yeah, definitely.
and if anybody in theatre tries to say to us, "Well, we haven't got enough space in the theatre tonight for the emergencies. You'll just have to wait till tomorrow," no,
Yeah,
we don't want to do that. We'll do
yeah.
the surgery tonight. Thanks very much.
Great. Okay. So dry socket or alveolar osteitis for those that want the proper term, which is either the clot hasn't formed correctly or it's disintegrated very prematurely in that socket. So you've got pretty much what it says on the tin, a dry socket. And this, if you look in the literature, it's up to 5% of extractions, and we know that there's contributing factors which can be trauma, difficult extraction, that mechanical damage as a result of excessive force increases the risk of releasing inflammatory mediators that then obviously they induce that conversion of plasminogen into plasmin, and then that acts to dissolve that blood clot. Smokers, uh, it says in some of the literature, nutrient deficiencies or immunocompromised. I'm not. I'll run with that for the minute. The oral contraceptive pill in females, and usually the mandible's more affected than the maxilla. So again, I think inexperienced operators is a classic as well, but also those patients with poor oral hygiene, dental neglect, they're much more at risk of dry socket. Uh,
It's interesting that your student group has a higher incidence of dry socket than perhaps you would normally expect.
yeah, but I mean, though that data is from patients coming to the acute clinic, which are patients that don't have GDPs,
Oh, right.
so it might be slightly biased.
Yeah, a slightly different
Um,
patient group, haven't you?
Yeah, it's a different population cohort. So, and then there's lots of studies looking at how we manage this, and certainly how we manage it is they may, as you touched on earlier, they may need some local anaesthetic. Make
Mm.
sure you've got your diagnosis from your history, and it's usually that pain that is fairly well localized, and it is just not controlled with over the counter analgesia. Um, I sometimes give local anaesthetic if it's really uncomfortable. Some people might argue and say, well, you're causing vasoconstriction; it might cause further risk with that clot. But actually, I think if it's that sore and you can't get in there, then you've got to give them some local, haven't you?
I think that's just the kind thing to do. And
Yeah,
yeah, I accept that there might be a bit of vasoconstriction, but I think that's the kind thing to do.
yeah. And then we irrigate with saline. There was a time when we used chlorhexidine, but since the risk of anaphylaxis or certainly reactions to chlorhexidine and open sockets, we've steered well away from that.
Sure. I still find that people are being taught chlorhexidine irrigation. It's a curious thing. It's not something that I was ever taught, so I've never been used to it. I've always used normal saline.
Yeah,
And of course, there are some cases, as you and I are both aware, which ended in tragedy
yeah.
as a result of chlorhexidine allergy. And it's interesting that our orthopedic colleagues used to use, well, they went from using betadine as a skin prep to chlorhexidine as a skin prep, and now some of them are moving backwards again because chlorhexidine allergy appears to be a bit more of a thing than it ever was.
Yeah.
So yeah, I agree. I would use normal saline.
And then we pack with Alvagel, which I think is fairly routine. Now, it's
Yeah.
interesting that there was some research that came out in 2020, and Alistair Sloan actually is on the paper from Cardiff, who's now at Melbourne. And they were looking at a novel dual action monolithic thermosetting hydrogel loaded, and this is the key, with lignocaine and metronidazole. And we're taught from the year dot, aren't we? This is not an infection. It's not a microbial problem. It's no antibiotics. And they got some results from this, saying that actually that there seems to be some benefit of the use of lidocaine and metronidazole providing pain relief and any pathological bacteria. Now, whether that's then the dry socket exacerbating to an infection is difficult to say from the research, but it's interesting that that's out there and it's fairly recent.
And out of curiosity, you've made me aware of this paper, but has there been a similar paper done but without the metronidazole in the hydrogel?
Not that I'm aware of.
Because I
This,
would
this was
be,
done at Cardiff.
yeah, I'd be interested to know whether it was just the protecting. It's
Mm,
covering the really painful bone surface that's the issue, or whether it's the antibiotic that makes it
yeah,
better.
yeah.
Curiosity, but it's a blooming
Interesting.
horrible thing for patients to have.
Oh, yeah, it is. Yeah, and certainly the other thing to mention is if we say to patients you might need to come back in 24, 48 hours for it to be redressed. That's fine,
Mm.
and certainly in our hospital we are very cautious. If they come back a third time, then I would be considering, is this actually alveolar osteitis? Because it's self-limiting. It should have got better or be getting better. If it's not getting better, then we need to be thinking about a surgical sieve and differential here. And is this something, it's a red flag, isn't it? A non-healing socket.
It is. I think it's a rarity. It's a serious rarity. The only thing I would be a bit cautious about, and I have seen previously, is the socket that fails to heal because so much Alvagil has been put in the socket under
Yeah,
pressure. I think it's one of these things that you should pack loosely into a socket, and it's not
definitely.
something that I would be, for want of a better word, ramming into the socket and plugging. And I have actually had to explore a socket. It was a lower third molar, curiously. And the lady ended up with numbness as a result,
Oh,
as a post op complication. And when I biopsied the tissue at the apex, it came back with lots of fibers in it. And then it was only then we realized it was alvagil.
oh, okay.
Um, so her numbness did eventually improve, but the
Right.
supposition was that it was an exposed nerve that had been somewhat traumatized with a good
The
plug of
Alvagel.
that.
Yeah. Interesting. And then, there's some literature to support if you put PRF in the socket after your extraction, you're probably going to prevent alveolar osteitis.
And do you think that's true?
Yeah, definitely.
And is that what you do in your own practice?
Yeah, routinely. Unless they don't want it.
And
Or
do you have a dry socket rate?
um I haven't audited it since we started. But we will be soon. In the trust we've only just got the machine coming. But privately, because I don't do that many extractions privately, it's more implants. It's I certainly should look at it, but it's
See,
anecdotally
I do
definitely,
audit my dry sockets for my
yeah,
private extractions because, as you know, I do quite a lot of extractions privately.
yeah.
And my dry socket rate is less than 0.5%, but I'm irritated every time I get one. Not only for the patient, but I mean
Mm,
it ruins my data too. But um, it's um, it's just one of these things that you do your best. It doesn't matter
mm,
how atraumatic your extraction is.
yeah.
And the classic is the lower root treated 6. Um,
Mm,
that you're taking out pre-implant, and you try to be gentle, and then just occasionally you'll get a dry
Yeah.
socket. I'd be interested to know what the your personal PRF audit
Okay.
is.
Watch this space.
Uh,
Okay, so you've just mentioned nerve injury, but we'll just touch on iatrogenic damage, which is something obviously we want to try and avoid at all costs.
mm,
Certainly, a pet hate of mine, and I know this might rub some people up the wrong way, is surgical emphysema. And we had I think it was last year, we had a systematic review published in the
mm,
BDJ looking at surgical emphysema due to dental treatment. So
yeah,
this is when air's getting into the soft tissues, and I know I'm fully aware that people section teeth, decoronate them with an air rotor. Personally, I think it's indefensible, and that's just my take on it. I
I
appreciate
can't,
them.
I
Sorry.
just I can't support it. It's just not something I can support at all. I know that an air rotor is a very useful tool, but when it comes to exodontia, I don't think it's the tool of choice.
Yeah.
Um,
And people will argue and say, well, if I'm doing a subgingival crown prep, what's the difference? But I think if you're purposefully either removing bone or sectioning a tooth, then
yes,
that to me is a surgical procedure in itself. That yeah, I totally agree. I appreciate that some general dental practitioners don't have a surgical motor, and that
mm,
there is a cost implication for that. But it's not a huge cost implication, and certainly the other thing is you can get reverse air exhaust air rotors,
yeah,
which is common practice in the States. So
yeah.
if you do see stuff on YouTube or on social media, it's completely different. But it's not doesn't seem to be common practice in the UK. Now on our review, nobody died, but the outcome generally for these patients is at least 24 hours on ITU, maybe
Mm,
ventilated with supportive therapy, which can sometimes include inotropes,
mm.
ventilated, and steroids and antibiotics. So nobody wants to land on critical care for a night unless if it's preventable.
In my now 30 years, I've seen two of these patients, both of whom had air in their sort of pericardial sac,
Mhm.
and it's not a good thing.
No, yeah.
So I
It's
can't.
entirely preventable. I think that's the bottom line for me.
Yeah,
Um, and then other common iatrogenic things like heat injuries. It happens. It's probably more classic in general anaesthetic setting because you sometimes you're not conscious of where the handpiece is. I mean, certainly the surgical motors don't seem to get that hot, but it still happens, doesn't it? Or the burr gets wrapped around some soft tissue.
yeah.
So it's something to just be cautious of, really.
Um, I, as you know, because you and I've worked together before, I have a real issue about protecting patients' lips with retractors.
Mm,
So it's beholden on you, particularly when the patient is asleep, to protect that patient's soft tissues. To some extent, I think it's a little easier when the patients are awake, or you pay more attention
yeah,
to it
yeah.
when the patients are awake. But you and I have both seen some really nasty lip
Mm,
injuries. And patients don't do well with these injuries. They react very badly to them in lots of ways.
yeah.
And it's so preventable. It's incredibly preventable. But it's things like one of a practice that I'm aware of was using surgical drill bits that were too long for the handpiece. So you end up
Oh,
with a long piece of rotating instrument, and that's going to get caught up in tissues.
yeah,
It's not worth it. Um, and we were talking about iatrogenic injuries. I think choosing the right piece of kit for the right job will help you stop making any iatrogenic injuries. And as you and I have discussed before, I've got a bugbear about round burr versus straight fissure burr, um, and I prefer the latter, as you know.
mm,
Uh, that again is about preventing iatrogenic damage. You
yeah,
shouldn't have to take huge amounts of bone away from patients to jaws to take teeth out. It's just not necessary.
yeah. I mean, I tend to use an Optrogate and a Minnesota retractor and the Minnesota is parallel to my handpiece, so it's almost
Yeah.
the fulcrum or resting on that. And I just like the Minnesota for that reason. Things like rate retractors, I think, are more prone to cause iatrogenic damage, even to your flap.
I would rather use a Minnesota any day than a
Yeah,
rake.
Yeah.
There are some rakes out there that are okay because they have slightly gentler teeth. Some of them have really
Mm,
teeth. And the Optrogate I've used too. I think there's something that you have to get used to. I think there's something you have to use regularly.
yeah.
And the patients look a bit alarmed sometimes when you produce this thing, but I think they're quite good.
Yeah. If
Uh,
they smile or laugh, you've had it because it shoots across the room. But
that's
if they're
true.
asleep, top tip: if they're asleep, you need to get it on before your anaesthetist connects their tube. Um, so I'm always poised as soon as they've come into theatre to throw my Optrogate over the airway.
I've never used them, I must confess, in their sleep patient. I've only used
They're
them
a
in
bit fiddly when they're asleep,
imagine.
but they do make a big difference. The only issue is sometimes if you're working anteriorly, they do get in the way.
Yeah.
Um, okay, so let's move on to the antrim, which is common. Another common question, tuberosity fractures, oral antral communications. Tuberosity fractures. I've seen one really nasty one that bled heaps that came in when I was a junior.
Mhm.
Um, And I don't know what your experience is, but quite often people will say, well, if the tooth comes with the tuberosity and it's bleeding a lot, keep it on the forceps and put it back in to plug the hole. Um, I don't know
I
what your thoughts on that are, providing it doesn't go into the antrim, obviously.
I think if it's a very big fragment, I think that's for some of our primary care colleagues, I think that's a useful approach. I think if your skill set includes it, a lot of us, if it's not too large a piece, will actually take the piece of tuberosity out with the tooth.
Yeah,
But that does entail quite a lot more dissection. And it can leave a slightly unusual shaped tuberosity, of course, because you've got a deformity at the end. Um, I find sometimes the guidance about if the tuberosity is going to break, put the tooth back in and then bring the patient back another day. I find myself frustrated with that guidance sometimes, insofar as, well, the patient might still be in pain. And then you're hoping that tuberosity fracture is going to heal, when you and I both know that if you put some pressure on that in 6 weeks or 8 weeks' time, it's probably going to break again. It's just
yeah,
somebody else is going to break it. I think forewarned is forearmed here. I think anybody, when you look at an x ray of somebody's 8 and a tuberosity, the shape of it is critical. If it looks like a table, it's going to behave like a table and it'll probably break. So if it's got
yeah,
a back, a top, and a side on the tooth socket, then it's probably going to come off. If it's slightly more pointy or rounded, I think you'd be unlucky. But I mean, by and large, if it's a small fracture, I'll take it out with the tooth.
mm,
What you
yeah,
would do.
yeah, and certainly these patients, that then may lead on quite nicely to an oral antral communication, which is communication between the mouth and the antrum. But that can happen in other dentition. Doesn't
Yes,
necessarily have to be a molar tooth. I've seen it in a premolar, and again, it's all about looking at the radiograph preoperatively and
absolutely.
predicting that likely complication.
Mm.
Now, I think if it happens and if you've got the skill, then you want to close that OAC. If
Yeah,
in and this is just, I don't. You can tell me what your advice would be. If you take the tooth out, look in the socket, and think, not really quite sure. I certainly wouldn't do a Valsalva because just personally, I think if the lining is intact and you do a Valsalva, then you'll certainly create an OAC. Um, if you're not sure, I'd probably do an antral regime.
I think that's
Um,
fair.
yeah,
As you know, if you put a sucker,
yeah,
nurse can give you the sucker, and you put your sucker up into the tooth socket, but not too far, you will get a very distinct note when you actually through into the antrum. It changes. It sounds hollow. It's very obvious when the first time you hear it, you'll know what it is. If I'm not sure, then I'll stop them nose blowing. I will.
hmm
I might give them antibiotics. I may just stop them nose blowing. And of course, if I take any upper molar tooth out, do you put that in your warnings for your
yeah,
consent form? Yeah.
yeah, routinely.
So, and I will tell the patients, I'll say, listen, although I don't think there's a hole, if I don't think there's a hole, it's possible that you could blow this through because it might just be a very thin piece of bone or possibly even a piece of mucosa or a piece of antral lining. And I think it's reasonable to say, don't blow your nose.
Mhm.
The other thing I will do you use any of these collagen dressings, these things for maintaining bone height?
No, you know what I'm going to say that I
Yeah.
put in PRF.
Well, of course, you've got PRF. I haven't got a PRF machine, but I
Well, buy
do.
yourself one. Treat yourself.
But I do have the likes of Colocone, and in the upper 6 or upper 5, wherever in the upper, where you think, "Oh, not sure." Do you know what? It gives you a little bit of stability to your clot, hopefully, although I can't say that it prevents a dry socket because a Colocone doesn't. Um, but I think it gives a little bit of protection to that socket.
Yeah.
If I'm not sure, I will never. If I see have a situation where I don't think there is an OAC, then it's not going to get any extra stitches. I'm not
Yeah.
going to raise the flap for that. I will only raise a flap when I think there's definitely a hole because it's
Mm.
actually quite a thing to do. Patients get quite bruised and battered after a flap sometimes.
And,
Uh,
I know some people recommend putting Surgicel in to help uh,
I
help the
would,
clot form. Now, my only worry with that is that the Surgicel might end up in the antrum,
yeah,
and you might be in more bother. So I think, and I know people have argued with this with me, and I think if you're dead set on putting Surgicel in, I would suture it to the edges of the wound to make sure it doesn't go up into the antrum.
and
But that's my worry.
I think it's unlikely to go up into the antrum. I think that would be you'd be most unlucky if that happened. The other thing I would say about suturing is it turns to jelly pretty quickly. So I think you'll be suturing a piece of jelly. Um,
Mm.
and I think if I was going to encourage you to stick anything in there, I'd be going down the perhaps something like Colocone. One of these little collagen dressings would
Yeah.
be better than Surgicel. And Surgicel, it's just not very stable. At 24 hours, it's often hanging out of sockets, isn't it? Like a
Yeah.
little
Yeah.
string. So I
Stringy.
don't think,
Yeah.
yeah, it's just, and the patients don't like it. So I wouldn't be going down Surgicel. I have seen somebody pack a socket. We were talking about Alvagil earlier. I have seen somebody pack a socket with Alvagil where they thought there was an OAC, and that did end up in an antrum.
Ah.
So yeah, it's not. That's not a preventative. That's a treatment. It's not a preventative.
Yeah. And one of my registrars has got a good saying for patients with a suspected OSC: do all the the no nose blowing, consider decongestants, analgesia, maybe antibiotics. I think you need to have a good reason for that. But also, he says to them, just sneeze like a horse if you need to sneeze.
Yeah,
And that,
I tell them that they have to sneeze in the revolting way. So
yeah,
it's sneezing. I don't know if I'm allowed to say this. If you're out in a field and you're on a walk, you don't tend to get your hanky out. You just let it out. You know what I mean?
Judith, people don't have handkerchiefs anymore.
I do. No.
um, and leading on from OAC, OAF, because often people get confused. So the OAF is a fistula, so it's that epithelial line tract where it's tried to heal and hasn't. And certainly for the other thing, an OAC referral, it's not life or death. It doesn't need to happen the same day. We often get phone calls.
Yeah, and I feel sorry for these guys because they feel bad for their patients
Yeah,
because they've
yeah,
taken the tooth out, they've made a hole, and then we say to them, "Well, I'm sorry, it's not an emergency," because sadly, it's not.
yeah,
It's annoying. Now, one thing they could do for the patient to actually get the patient comfy is make them a little cover plate. If
yeah,
they make
indeed.
like an Essex, then they're going to stop food and debris and rubbish getting up into the
Yeah,
antrum, and that would probably reduce their risk of infection.
yeah.
So that's something to consider, but sadly we can't treat them as urgents.
And just while we're on that, the other urgent referral we get is a root in the antrum.
Oh, yeah. Well,
And again,
what do we do with those? We used to go looking for lots of them. In the olden days, we do lots of Coldwell looks. Now, a Coldwell look sounds like a great procedure, but the antrum is well, it's not that easy to get roots out of or implants out of
no.
the antrum. It's quite difficult to get them out, and you actually need something often that's got an angle in it to get it out. So sadly, roots in antrums aren't urgent procedures either,
Yeah,
and it's a curious thing that often patients will settle.
yeah.
Um,
And just out of interest, have you got ENT colleagues that'll go in endoscopically?
yeah. However, I know they've got the scopes, and occasionally I can persuade them to do so. But by and large, they say if there's no evidence of obstruction, no evidence of infection,
Yeah,
they'll leave them where they
yeah,
are. And
yeah.
we have had a patient actually blow one out when he blew his nose.
Oh, lovely.
So basically, it managed to work its way up to the osteum, through the osteum, and came out, and the nuts all
Shut
top.
out. Oh,
Yeah,
gosh.
yeah, not very
Big
nice.
ostium.
Yeah,
or
well,
small root. I don't know.
I think it may have been a previous sinus patient, so it might have had
Ah, okay,
previous
yeah.
sinus.
And I guess the thing with the fistula is, again, onward referral, and we'll excise it and close it appropriately. Do you always send that off for histo, just out of interest?
I don't.
Okay,
But I would do if I thought there was anything unusual about it. Don't
sure.
forget, most of the fistulae that we see they don't have any horrible granulations in them. They are just little holes.
Yeah,
If I saw anything that looked like it looked unusual, I would send it off. Now, just occasionally, you'll get somebody who produces a little polyp that comes through the antrum, so through the fistula. You ever seen one of those?
mm,
It
yeah,
looks like a socket that's healed with a
yeah,
blob sitting in the middle. I would send that away.
yeah. Okay. Well, okay. So nerve injury. We'll finish on this. So again, it's not common. Well, I'm going to say that in the loosest sense of the word. We do see it, don't we? But I think perhaps we don't see permanent nerve injury as much as I don't know. Do you think?
I don't think we see very much at all, but I think we see. I mean, let's face it. I'm sad to say I've been around long enough to remember the nice guidance coming in. So when I was a junior on the wards many years ago, if you had wisdom teeth, you're left without them. It sounds glib,
Mm,
but that's pretty much what we did. So I've seen the transition between pre nice guidance and post nice guidance. So I think we see fewer patients with nerve injuries, and that's a good thing. But I think we see a lot more patients with complications resulting from retained wisdom teeth,
yeah,
than,
yeah,
and that would reflect the most recent guidance, would it not?
yeah. Sure.
Um,
And nerve injuries can be caused by all sorts of things.
yeah,
Is that argument about local anaesthetic? And
yeah.
again, you'll never know if you've given an ID block what's caused it, whether it's the needle, the solution, pressure, and we could talk about that all day. Third
I was
molar
just about to
removals.
ask you a question about it.
Sorry,
I was just about to ask you a question about it, but I
go
think I
on.
know the answer. When you do a lower third molar, I think you are local infiltration now, not IDB. Is that
I'm
correct?
Articane all the way.
Join the club, and I think it was you that convinced me actually in the
Good.
end. So,
Yeah, well, that's my time at King's, I'm afraid. But it doesn't work for everybody. I
no,
appreciate that, but I
yeah,
think those
absolutely.
patients, particularly in primary care, where they've sustained a nerve injury for whatever reason,
Mm,
um, and I think I can't remember if it was earlier this year. It was end of last year, I think, in BJOMS that we published um, a survey of nerve injury management in the UK, and basically the outcome of it, I'll put a link in the podcast, is that it's poorly managed, or people don't really know what to do, and everybody's doing something different. There are certain centres in the UK that specialise in nerve injury management, but certainly those, when you refer to your local MaxFax unit, when should you refer, and what should the management be, really? Because certainly if you listen to some of the literature in the States, they're like, hit them hard with steroids early, anti-inflammatories,
mhm.
B12.
Yeah, they've got all sorts of clever things. I think the Americans are actually they're much more organised with it than we are. I think.
Yeah,
What if somebody would contact us and say, I've got a patient that I've taken a wisdom tooth out of and they are numb, I would see them the same week.
yeah.
Uh, they are to me way more urgent than the oroantral communication or the root in an antrum,
And would you
because
CBCT them?
yes, all of them.
Yeah,
And I think it's beholden. I mean, it's beholden on us to make sure that we know what's happened to that canal. We know whether there's any roots or bits of stuff around or bits of bone, for example. I think it's important that we know that. We've got good access to CBCT, as indeed do you. And I think it's important that we do that. The difficult bit and the bit where it falls down is what happens to the patients after that. So, although we might see them urgently, there are times, as you know, where patients, it'll be, oh, we'll come back in 6 weeks and we'll see how it is. When in actual fact, our colleagues in the trigeminal nerve repair units want to see those patients soon. So there's a very nice, I think I've seen this, I think you've sent it to me. There's a very nice flow chart from Sheffield about
yeah,
what to do and when, and I would
yeah. There is.
all try and follow that where possible.
Yeah, definitely.
Because the sooner they see them, the better the outcomes are likely to be.
Yeah, totally agree. So just to finish, Judith, top tips?
Top tips. I, as you know, have this thing about future proofing. So, and by future proofing, I mean thinking about what you're going to do if it all goes wrong. So, what you're going to do if it starts to bleed? What are you going to do if you can't get the tooth out? So, it's about preparation and planning. And that sometimes is about imaging, it's sometimes just about taking the correct history. And if you're not sure, don't do it. Does that
Definitely.
sound sensible?
Yeah, totally agree. And there's very little, certainly in oral surgery, that's same day surgery, isn't it?
Yeah.
It can usually wait. It's usually elective.
And
Obviously, in a hospital setting, that's different. But
there are always people out there to teach you, to help you. I'm always happy to go to practices and teach people. It's what we do, as you know. And there's no need for people to do things that they're not happy to do. And they shouldn't have to do these things. We're always happy to teach.
yeah,
Now, having said that, as you know, also from your PhD work, we see a lot of very routine exodontia coming into the hospitals these days. And I think if we can be there to offer a bit of encouragement, then I would rather do that than inconvenience the patients and send them into hospital. So, and I think our dental colleagues are a lot better than they think they are sometimes.
yeah, definitely. Super. Well, it's been brilliant. Thanks very much for your time, Judith. And we'll chat soon.
Okay.
Bye.
Bye.
Thank you very much for listening to this podcast, and any resources will be linked in the description. Please do leave a review and rate the podcast on the iTunes store. I hope you join me for the next episode. Goodbye for now.